Greeting. My name is Kent Schafer. I'm a predoctoral intern under the University of Alabama, working with University of Alabama, Birmingham with Barks Clinic. I'd like to give thanks to my supervisor, Dr. John Hauser, for providing me the opportunity to work in the field and participate in Make Lifelong Connection 2021. I'm excited to be here today. I would like to talk about just a brief abstract presentation about cultivating resiliency, especially in the medical model, how the medical model often asks people to change to fit into their current world, and there's a need to transition towards a deaf model, reframe that perspective towards a culture and linguistic diversity. Those types of neurological differences are just another dimension of diversity. People with hearing loss, they think differently, they respond differently, and they learn differently, especially when they lose one of their senses. It becomes tricky in the intervention world. Consider textbooks with misinformation on deaf and hard of hearing and speech, audiology, language, and accessibility. There's a lot of bias in that area. I often find myself thinking about, does the author have a personal experience of being deaf themselves? Those barriers slow down acquisition. We are rarely acknowledged for the heavy burden of accommodation that is necessary to cope in order to survive, while it is other people who believe they are making the accommodations. Those burdens are placed on us. I may never be able to learn to hear again. I don't know about speaking, but I can definitely learn through a visual medium and share through that discourse. I have a dream of a perfect world where we have individuals who can speak Spanish directly, assess Spanish-speaking individuals, but we do not have deaf individuals to treat and assess deaf children in American Sign Language. There is a need to create an environment to support people like me and others to learn alternative strategies as we learn how to modify and assess deaf individuals. There's not a lot of visible characteristics that may set a student who is deaf apart from the crowd. Only when the demand of communication enters the picture do we see the severity of the disability, especially since we are people of the eyes. There's a need for advocacy, for accommodations, creating space, and working towards, in a small room, it becomes difficult working with an interpreter for making accessibility. It's really challenging trying to accommodate with interpreters, individuals who are deaf assessors, and regular folks who do the assessment. Deaf people work harder. It could be harmful, especially when we have that philosophy or approach. Deaf people need to work harder or just try hard enough. And considering how we have 4 senses instead of 5, the evidence-based practice is limited for the field of deafness. There are certain methodology issues, limited sampling pool, and assessment instrument validity. When we bypass methodology, there are significant stresses. There's a need to create ideas or modify assessment or instruments, and we have to learn how to revise those in order to provide some kind of measurable results. That type of instruction with the medical approach often end up encouraging us not to sign. We think that by avoiding sign language we can focus on speech and hearing, and there's a need to focus on that, while sign language is repressed. That is puzzling for me from the medical professionals who want to encourage baby signs for regular individuals but discourage those for who have deafness. That creates a form of language deprivation. At the same time, those professionals who teach baby signs or pick them up will often drop it the moment speech enters the picture. Why don't we encourage babies and parents to continue baby signs developed by bilingualism? Why do we keep removing opportunities, especially when the brain has to overcompensate and develop experiences to survive traumatic environments not designed for the eyes. Those visual gestures and the information become selective and limited. It may create lower literacy levels, a lack of social emotional coping skills, or behavior problems, especially when communication through visual medium becomes a primary form of communication. We find that it's not often about the child being deaf, but it's about if they have language or not. Do they have accessibility to information in the way they are able to receive it? Are they being taught in a way they know how? Or do they have to work on cognitive resources to supplement whatever spoken language demands are? When we think about navigating content relevance, ASL is a language every child will benefit from. One thing I've noticed, translation causes what we call a flash pan moment compared to overall loss and nuance. Interpreting is incredibly stressful and fraught with opportunity to miss certain elements. Communicating is hard enough when you're not mediating your own thoughts through someone who has limited to no exposure to doctoral level constructs. The correct word use carries with an entire monograph information to other academics. Consider the word dialectic and difference. Both have the same sign concept, but they all mean two different things. Big difference when you consider that sign and that experience in the academic environment. Dialectic versus difference can lead to two different trains of thoughts. I've noticed in my experiences so far in the internship, I've been considering how to modify test and administration. I've been researching more about neurodevelopment risk factors associated with language deprivation. I've been looking at distinguishing autism and deafness when they have overlapping factors between social skills or communication deficits. I've been experiencing more about different communication modalities through interpreters or captioning. Print and sign language are two different things. They have nuances, information, content, at the same time a different cognitive load and emotional load to process the information. How can we develop more testing that are language free? How do deaf individuals bypass phonological processing? There is a need to continuing to distinguish processing and perception, especially with people with the eyes. It's a good question for me to pursue, thanks to Sparks Clinic. When I'm thinking about sign language, there's a lot of gross motor skills to reconstruct language, or even pronoun usage of pointing in which direction. I've started to notice that language disorders could be either neurodevelopment, or they could be from biological factors with deaf and hard of hearing individuals. Last but not least, the most important thing, thanks to my experiences and frustrations navigating with the support of Sparks Clinic, and thanks to my second opportunity through COVID, a trauma-informed care framework for the future of deaf mental health supports, especially since we had to adjust through that experience with COVID. I look forward to discussing with you today about this short poster presentation. Cheers.